Good afternoon, everybody. I come from this place north of Delhi called Chandigarh, Mohali, if anybody doesn't know where Mohali exists. People, everybody like the fellows, I'm sure by this time they know three different types of things we are talking about: an open aneurysm repair, thoracic endovascular aneurysm repair, and EVAR is endovascular aneurysm repair of abdominal aortic aneurysms. So why do we need to follow up these patients? It's very important. So you look up, even if you look up at open abdominal aortic aneurysm repair, once we repair it, these are sort of complications which are reported in the literature. Anastomotic aneurysms to the order of 10 to 20% at 10-year follow-up, an infection 0.3 to 0.5%, incisional hernias, and graft limb thrombosis at the order of 3% at 10 years. So it's not only aortic stents which we need to follow up, it's also an open surgery. But open surgery is much more robust than an endovascular stents. Now let's take up one or two examples to see why do we need to follow up after stenting. Look at this guy who had a thoracic aortic stent, a young male with a road traffic accident, had an abdominal aortic aneurysm. It's a pseudoaneurysm after rupture. Put in a stent, CT angiogram before discharge. You can see the graft is not properly placed here, which is there. It's a thoracic aorta, and there is a potential for endoleak. So he was rightly followed up. And at a CT angiogram done at 1 month, what you see is a total compression of the stent graft. So patient presented with a very high blood pressure. Similarly, in an abdominal aortic aneurysm, where patient had a celiac artery aneurysm here, which was repaired with a stent graft. This is a CT scan done 1 year on follow-up. When we did a CT scan at 2 years follow-up, you could see a pseudoaneurysm or the dilatation of the abdominal aorta here, which was managed with an hybrid procedure. So similarly, another guy who had an aortic stent here, left renal artery stenosis, which was not managed, and you look at the follow-up CT scan, the kidney was there, but then it has atrophied because of left renal artery occlusion. So it's very important to follow up all these patients in your clinical practice. And even if you look at the trial data or whatever the published literature, the intervention rates after stenting is quite high, it's order of 8 to 10%. But with the advent of newer technologies, the reintervention rates will decrease, and we have got better understanding of what sort of leaks we should manage or not. Reinterventions are mainly because of device failure or migration. See, if the first time the device is properly placed, then chances of migration becomes a bit low. So otherwise, you see some sort of like leaks in the aortic sac, like type 2 and type 3 endoleaks, which needs to be managed. So what are we looking for? What we're looking for is an endoleak. I'll not go into detail because the next lecture is on endoleak there. Then endotension, device failure, migration, kinking, and thrombosis. And what is endoleak? Just in simple terms, any leakage of blood outside the stent into the aneurysm sac we call as endoleak. And there are various types of endoleak which are there. So the follow-up protocol, it depends on clinical situation, and we need to do the investigations periodically. And there are various investigations which are there. One is a CT angiogram. That's quite a gold standard, very good investigation, but it has got drawbacks of radiation and the contrast. Then we got a duplex scan, MRI, then got 2 invasive investigations in terms of pressure measurement and IVUS. IVUS is an intravascular ultrasound, so we'll not discuss the invasive investigations because feels that we should not use it for regular follow-up of these patients. Similarly, in thoracic aorta, we got an X-rays, CT scans, MR, and intravascular ultrasound and transesophageal lithography, and IVUS and T are both invasive, so we will not discuss that. There are 1 or 2 slides for non-enhanced volumetric CT scan. What that means is you do a CT scan, but without giving a contrast. So you got a disadvantage of radiation, but not of the contrast. Now these are the data which has been published on this. If you have a mean volume decrease, minus 3.2% in patients, normally without endoleak. If you have a type 1 and type 3 endoleak, normally the volume of the aneurysm increases by 10%. And if you have type 2, that the volume increases by 4%. An important thing is that any endoleak which is associated with minimum aortic volume increase of less than 2%, did not require any intervention on the follow-up. One or two slides on duplex scan or a contrast-enhanced duplex scan. This is very good to pick up an endoleak, especially if it's a contrast-enhanced duplex scan. It increases our sensitivity to pick up an endoleak, but it's not very good for a stent migration. MRI and CT, if we compare with the newer technology which is coming up in the MRI, the sensitivity rate for MRI is much better than CT scan. So in the follow-up plan, you have to individualize the plan to each patient and each center. And the things what you need to look up as has the EVAR or the TIVA, which has been done. What are the renal functions of the patients? What sort of endoleak is present? Where the stent is positioned in the first time? Follow-up CT or MRI stent position is good or not? What are the types of stent? Is it an ethanol stent or a stainless steel, because where you can't use an MRI? And what is the local facilities and expertise which is available? Let's say contrast-enhanced duplex scan facilities are not available everywhere. So what we follow is the protocol is we do a phase 3 contrast CT scan. If there is no endoleak, we follow up 6 to 12 monthly. And if the patient is stable, we do a duplex and X-ray 6 monthly. If there is an endoleak, 1 and 3, we intervene. If it's 2 endoleak, we do an angiogram 6 to 12 monthly and an yearly follow-up. Thank you.